Hello class and welcome to one of the final lectures for 4401. We primarily are going to be focusing on COVID-19 this week in terms of, well, what does it really mean in the context of being an American, really? And with that, I'm going to be showing you a few clips and also sound bites, let's say, for instance, on NPR. So my actual lecturing is going to be on the shorter side, so just make sure that you watch and listen to the clips and videos that are provided. And remember that there are a lot of deadlines, not just in my class probably, but for every class rapidly approaching. So use your time wisely, and I look forward to reading all of your different papers too. I'm going to go over some quick due dates sort of for your big assignments for the rest of the semester. And really, there are three of them approximately, as you will see here with the due dates. So first, there is the key issue reflection paper, which is due on Friday, November 27th. If you have any questions about the feedback that I had given you on your reflection paper outline, feel free to reach out to me. Just know that it is, of course, the end of the semester, so everyone is busy, including myself, so I'll try to get back to you as soon as possible, but the earlier you reach out, the quicker I can get back to you in terms of what is the expectations for this assignment. Then on December 2nd, so shortly after that, you will submit an individual paper concerning your GEA2 interview about a key issue that you identified after conducting the documentary summary assignment earlier on in this semester. So you will give me basically a summary of that interview, and I gave instructions in a separate lecture on what I'm looking for, as well as look at the assignment guidelines to get an idea of what sort of you need to have in this paper. Then on that same day, you will submit basically a summary of that summary, a distillation, if you will, of your interview on the GEA2 discussion forum so that other students can view the kind of work that you conducted and they can see the topics that are pretty wide-ranging from my understanding of what you all are talking about so far in terms of what this class has made you all think about in that sense. While you're there, you might as well reply to another student because in 2 days that will be an assignment deadline as well. So GEA2 forum post on the 2nd, and then at least by 2 days after that, you will reply to at least one student, basically commenting or reflecting on what they talked about as a way to sort of engage you all with each other at the end of this semester. Then the very last assignment for this class is the intervention proposal. And you will see that I give examples of that for students to kind of view and help think about how you want to frame your own intervention proposal. I also have given a lecture on that likewise, and if any questions up until the deadline, again, feel free to reach out to me so I can help you along and point you in the right direction at least. So I look forward to reading all of this work from you guys. I'll be very busy reading papers at the end of the semester. And good luck. So kind of kicking all of this off, I would first like you all to watch this clip. You don't have to watch the entire thing. And I would preface at the beginning is a little cringy, and you'll probably see what I'm talking about as soon as you start it. It goes over some anthropological careers and some of the work that anthropology currently is doing on a variety of issues. I say currently, of course, because this is a snapshot before COVID, and anthropological work is actually kind of difficult to do in the post-COVID or during COVID period. Remember, thinking about the kind of work that we often do. We're going to communities, we're talking with individuals, we're interacting with them, we are observing their behaviors, we are conducting the behavior ourselves using personal observation. That's really hard when there's an infectious disease out there that's very easily spread through the air and through contact with others. So how does anthropology sort of adapt to that is something that, or adapt to that, is something that has been on all of our minds lately, including myself. For instance, if I plan on going to Belize, I'm going to have to think about how I'm going to restructure my entire research agenda, assuming there is still COVID to be a concern, and I think it will be. A lot of anthropology students in my department, for instance, are switching their focus to looking at COVID-19 when they may have done something very different, let's say talking about refugee resettlement in Sicily. So people are having to sort of restructure and think about, okay, what is manageable in this context? I think that kind of echoes what you all probably have had to deal with throughout the semester also too. But just know that it's also a concern for professors as well, to try to wrangle with how to best provide digital content, seeing as there's limited face-to-face interaction, which is, I think, a benefit of anthropology generally, is that sort of back and forth with students and professors, which I think, of course, has been lacking in this semester since I'm teaching you asynchronously, of course. So keep that in mind as you're watching this clip. And remember, you don't have to watch the entire thing, and I'm not really going to police you for it. I just wanted you to have a sort of breadth of understanding of the kind of work that's out there right now. Then, in terms of the now, I think it's also important to talk about COVID-19, and that's sort of the primary focus or the lens in which you will look at issues in this presentation and also the next one as well. So if you haven't already used your 1-day allotment of New York Times, they usually only allow you to watch or listen to or watch or view 1 page per day for free. Please check out this one from around May concerning the You Can't Close America demonstrations. This is around the time, remember, in May, where countries and states really were starting to more or less lock down certain sectors of their economy and of the overall daily interactions with others as they tried to, again, more or less control the spread of COVID. There are some states, there are some countries, there are some counties that really didn't do too much because they were either, let's say, COVID deniers, or they were concerned that the economic cost in the short term outweighed the economic cost in the potential long term. It became a more pressing issue. And on top of that, we had individuals, in this case in Texas, protesting lockdown measures, saying that this is somehow un-American, this is somehow infringing on your rights, even though those rights often could not be articulated as to how they're exactly being violated. But this really hasn't stopped since COVID became a concern for the most part in the United States, especially in, let's say, conservative areas that are very much resistant to having to, let's say, conduct lockdown measures, as an example. So let's look about this in terms of the now, because this was a snapshot in May. We then have an example, let's say here, this is a screenshot basically of the clips. You don't need to watch this, but it says South Florida bars packed after governor gives okay for phase 3 reopening. Executive order signed Friday lifts most social distancing and mask guidelines. This is interesting to me as an anthropologist because I think for the most part, a lot of Floridians were doing a more or less poor job of controlling COVID anyways, and we're seeing that in the amount of cases that we have. So think about, let's say you're going to a grocery store, especially in the beginning of the pandemic, how many people were wearing masks? It wasn't really until there was a mandate saying you must wear a mask before walking into a business that people started doing that. But also that businesses are private entities. And for the most part, you're still seeing signs saying you must wear a mask. But then, for instance, when I went to go get my car tuned up at a mechanic, none of the mechanics there were wearing a mask. And I got a funny look for wearing one when I was in there also, too. So it's unfortunate that politics kind of influences, largely in a negative light in this case, the spread of COVID-19. But also Floridians, and it's actually interesting because there's a lot of parallels with COVID-19 and, let's say, hurricane preparedness or lack of in the state. As an example, a lot of Floridians are kind of ambivalent towards hurricanes. This is something that you kind of just deal with. Oh, I'll go buy a 12-pack of beer and kind of just wait for my power to come back on. That more or less is the approach to COVID-19 for a lot of people in the States. Again, Florida is very conservative, and you saw that during the election, of course, and then there's these pockets of more liberal ideologies and thinking, largely in the sort of more densely packed or urbanite areas for the most part. But a lot of Floridians are very resistant to lockdown measures. There are plenty of bars that you can just Google as an example right now, showing photos of people just packing them to the brim. The individuals, no one's wearing masks. People are going to restaurants and taking off their masks as soon as they get to the table. You're probably hearing my cats, so I apologize for that. So keep all of that in mind, and please, I urge you to try to stay indoors as much as possible. I know Thanksgiving is, well, this week really, and a lot of people are thinking about traveling, but I would just also mention the CDC is recommending that you do not travel. And if you do, you be very cautious. And I would please urge you all to be very cautious if you plan on seeing family members and friends over this very short break that we have. Breaking this down a little further, I'm going to go over something that really should not be a surprise to anyone that's familiar with the US healthcare system and the disproportionate burden of diseases experienced by persons of color as opposed to the general white population. So, the Centers for Disease Control, or CDC, found that 33% of people who've been hospitalized with COVID-19 are African American. Yet, only 13% of the overall population of the US is African American. Basically, what this means in public health language is that there's a high prevalence rate, meaning there's a high disease burden, among African Americans, disproportionate to that of other demographic groups, in particular white Americans. Now, there are many different factors that may be working together to influence this, and one of the tricky parts about doing epidemiology in a very rapidly changing context is that you don't really know what factor may be more indicative of being a risk factor. So let's say the four that I have here. African Americans are at higher rates or work at higher rates as essential workers in this context. So there's a larger amount of African Americans working fast food restaurants than there is white Americans. Being an essential worker, meaning you're currently working in this context, can increase your chance, your likelihood, your risk of getting infectious diseases, particularly one like COVID-19 that can spread via the air or water droplets. I say via the air, but that's because the water droplets can enter the air. So that's a very important distinction. Additionally, there's a bias in healthcare, well established in the literature, that African Americans or Black Americans receive less services than white Americans. So a classic example of this is an African American woman walks into a hospital and says she's having abdominal pain. The likelihood of her being prescribed medication for that abdominal pain is lower than if a white woman walks in complaining of abdominal pain. This is because there is a perception that Black bodies are more resilient than white bodies, meaning that they can take more pain, essentially. There's a long history of this tied to even slavery that has shaped how biomedicine largely sees Black bodies as being more resilient and therefore less in need of services. Of course, the doctors could also just be simply more explicitly racist, but the key point here is that Black Americans, African Americans, receive less services than white Americans. So, if they think that they, for instance, are not feeling well, they may decide they don't even want to go to the doctor. So then you have someone who's staying at home who could potentially have coronavirus but never even know about it. So this number may be even higher than the number that we're getting from the CDC. This is why understanding social context is very important in terms of epidemiology and diseases, because your culture and your perceptions of how you fit in society, your role in society, can shape the overall context of disease burden in the country, and also epidemiology in the process and the efficacy of surveillance. Additionally, African Americans or Black Americans suffer chronic conditions such as diabetes at a much higher rate than white Americans. So tying this to where you live, so let's say you live in a food desert or food swamp. Because the majority of the food that you're consuming is, let's say, fast food, or maybe even gas station food, you are at a higher risk for developing obesity or diabetes. And being obese or having diabetes can increase your likelihood of getting an infectious disease because your immune system is compromised from those conditions. And then finally, which is something that's tied to basically all three of these, is a history of stress faced by individuals. In the context of being Black or African American, this could be because of racism. Remember, tying this back to months ago in this class, racism can lead to stress. Stress can lead to having a weakened immune system. So these are just 4 facets here. I'm providing a link to an NPR article I would highly encourage you read. In fact, I'm actually going to reduce the overall length of this PowerPoint in hopes that you do read the article, because it really explores some of these different dynamics and what it means to be African American or a Black American in the context of coronavirus right now. Now I'm going to contextualize one disease with another. You may be very familiar with the Tuskegee syphilis experiments because they are often cited as an example of very unethical research. It is very unethical research. And because of that, there is a lot of rightly placed mistrust among African Americans and Black Americans in terms of the biomedical system that largely has seen them as test subjects. The mentality here is that, at least in our history, because African Americans or Black Americans were somehow perceived to be less than white Americans, they were an ideal test population. So why would we infect white Americans when we can infect Black Americans, was the mentality. So because of that, because of a history of racism tied to biomedicine in our country, because the population that this study was looking at was primarily poor African Americans with low education status, they were, in the minds of the researchers, an ideal population because they wouldn't really know what to ask in terms of questions, and they basically were signing up for free healthcare. One thing that I mentioned often when you're talking about the syphilis experiments is why participants even agreed in the first place. They were unaware that they were being infected with syphilis, but they were aware that they would be getting regular medical checkups, essentially. However, these checkups were basically intended by the researchers to see what is happening with the disease. This is called a life history study. Basically, what happens with this disease from time of infection to time of either cure or time that the disease eventually takes the life of the person. This, of course, is very unethical, and these are no longer done in most of the globe. I mention this because of this long history, and I'm talking decades of the syphilis experiments, African Americans and Black Americans are rightly wary, let's just say, of the biomedical system at large. This does not, of course, apply to every African American or Black American, but what we are seeing is that a lot of African Americans or Black Americans, I'll just say Black Americans for short, moving forward, are wary of the biomedical system. They get vaccines at lower rates than white Americans. Instead, well, that's not entirely true, because there are pockets, let's say, in very affluent areas where there's a large anti-vax movement that is largely white. But basically what we're seeing here is that there's a fear, despite African Americans having a high disease burden for coronavirus, that when a vaccine is developed, they may be less likely to utilize this vaccine. Think of Paul Farmer, and when he talked about having a preferential option for the poor. Basically, if we develop new vaccines or new medications that are proven to be effective, we should try to give first dibs, essentially, to the poorest members of society, because they have the highest disease burden. In this case, we're seeing a high disease burden among Black Americans, so it would make sense to give them the first vaccines. However, if African Americans or Black Americans are concerned that this vaccine, let's just say, hasn't been tested completely, or they're being seen as test subjects again, they may be less likely to utilize the vaccine. So they may be, again, at higher risk for complications due to coronavirus. Complicating this even further, looking globally, 2 French doctors very recently, you probably heard of this, they proposed that we should test Africa, essentially, with coronavirus vaccines. This caused outrage among Africans, among African Americans, globally, because this harkens back to this colonial mentality that we have this large population of Africans that we can use as test subjects, as opposed to testing, let's say, white Europeans or white Americans. This is colonial. So think about neo-colonialism. How do we basically extract resources or exercise our colonial power on the peripheral countries compared to us? So this could even be thought of in terms of Abdullah Gode's work with Muslim women named saving, and how there's this white colonial understanding that sort of underpins a lot of what we do, both in terms of war and also in terms of medicine. So there are multiple different factors that may be shaping Black Americans' perceptions of coronavirus, of vaccines for coronavirus too. So we need to be very careful with how we talk about diseases, because I know this from my own work with Zika, and you'll see this with other epidemics, how risk communication, basically how doctors, physicians, public health specialists, and the media reports about certain issues and communicates who is at risk for this disease, that language that we use can shape people's perceptions about diseases, about vaccines, and those perceptions can shape behaviors. So think again how you can't really separate culture from thought, because they build off each other. They're intertwined. So if you're changing perceptions, you're changing behaviors, which can then shape disease burdens. You can bring this back to the protests going on right now concerning the quarantine stay-at-home orders. If, let's say, people like Alex Jones in that video, who is an InfoWars guy, is telling conservative Americans, you need to go out and protest this because they are violating your constitutional rights by making you stay indoors. You're now creating a new context for the disease to propagate and spread. And let's say these conservatives start, and again, I want to stress this is not every conservative, of course, but this is a subset of the conservative population that is doing this. Let's say they get a large following and they start pressuring politicians that you should get rid of the stay-at-home order so that we can go back to work. This becomes more prominent. Politics can get involved, and people's perceptions and behaviors can shape politics, which can then also shape disease burdens. One more facet of this is coronavirus in the context of the prison system in our US nation in particular. So NPR has a ongoing playlist essentially of coronavirus reporting that they are conducting right now, of course. So I would highly encourage you to go through this and have a listen or read the articles because they're really interesting, and reporters actually play a critical role in shaping how people, the public, understand issues. So keep that in mind. In terms of biopower, again going back to Foucault's work earlier in the semester, biopower basically is the state's capacity and want to control people's bodies, their literal biology. That capacity is important because we give the state the biopower, the power to put people in prison, to incarcerate them. Because of this, a lot of individuals argue because the state, let's say, sections off a certain area, let's say this prison, they have a responsibility to maintain the health of that population, because that population doesn't really have a lot of say in their ability to, let's say, wear masks or practice social distancing maneuvers. So the prison system actually is getting hit kind of hard by coronavirus in certain contexts. Think about the prison system. Think about a prison as a building with a lot of people in it. A lot of people that are living very close to each other. The article talks about how inmates are living basically in barracks in a certain prison, meaning they're not by themselves. They may have multiple partners in the same room as them. So because of that, you can think of prisons as being a high-risk area for prisoners, as well as the staff that act as security guards or staff, let's say. As the article goes on, not many inmates can afford or have access to face masks, and they're openly coughing in the prison next to other inmates. So this is a very high-risk area, if coronavirus does enter a prison, because we don't really have a way to address this given how we structure prisons as an incarceration system. Then think about the demographics that largely are in prisons, are inmates. They're predominantly persons of color for non-violent crimes. So keep that in mind when you're talking about disease burdens in prisons and how societal barriers, let's say, to high education status, which is a known contributor to nonviolent crimes, and also racism, structural racism, shapes who's in prisons, who gets arrested for nonviolent, let's say, marijuana crimes. These people now are at higher risk for this disease burden, and they don't really have a way to prevent it because they have a lot less power in the prison system to make negotiations or be able to, let's say, quarantine themselves. I'm going to wrap up my presentation with this slide because I've given you multiple videos and links to check out. And also, I would really like you to read this article from Sapiens below. Think of Sapiens as basically a blog for a variety of different anthropological topics and issues. One was recently written on President Trump's language use, particularly him calling COVID-19 the Chinese virus. As Trump says in his words, "It's not racist at all. No, not at all. It comes from China. That's why. I want to be accurate." That, of course, is problematic because anthropologists have known for decades that the names we give to things can be profoundly consequential. Words and names define the building blocks, think social construct, from which we assume the world is made up. So, if the president is saying Chinese virus, and that gets used by both his constituents and also politicians, they begin to conceptualize this as a Chinese problem. So, an example, one elected official in Kansas said that social distancing was unnecessary in their county because so few Chinese people live in Kansas. Think about this. Because there is this thought that being Chinese somehow makes you a carrier of coronavirus, or you are able to spread it because you are Chinese. Chinese individuals, in fact, Asian American individuals or Asians that are migrating here, are being targeted for racism and are experiencing racism because of their perceived ethnicity. And somehow this ethnicity is supposed to play some role in them being carriers of a disease. Whenever there's a large outbreak, this largely happens. So for instance, when HIV/AIDS, the first epidemic appeared in the United States, a lot of Haitian Americans were stigmatized as being basically AIDS carriers because there was a perception that AIDS is something that happens over there. So these people are, in a sense, dirty. They're going to come here and make us dirty by giving us their disease. This, of course, is very racist. But even think about some of the language that the president has said concerning Mexican Americans or Mexican immigrants coming into the United States or migrant workers. He's been on record to say that these people, read Mexican individuals, are carriers of disease. It even mentions it in this Sapiens piece. So keep that in mind when you hear people say the Chinese virus and correct them. No, it's COVID-19. The World Health Organization actually does not allow diseases to be classified based on where they're from for this specific reason, because it can create stigma and it is very inaccurate. Because, of course, Chinese individuals or Asian American individuals are not more likely to transmit a disease than anyone else in the population. It's just where you traveled from recently and if you are currently infected. This has nothing to do with your skin color. So I'll leave you with that. And again, I encourage you, I stress you to please be very cautious with the words that you use, because words can shape behaviors. And if you hear people saying something that you think is very problematic, call them out on it. And you have the evidence to say what you were saying is wrong. And they might not even mean to be racist towards, let's say, Chinese Americans, but they are being racist towards Chinese Americans when they use this language.